Good morning, my name is Andrea Garza, and today we will continue the interesting cases session. I'm presenting a 19-year-old female, prima gravida, with 12 weeks period of gestation. She was asymptomatic on routine antenatal checkup, and she was sent for an ultrasound scan with serum beta human chorionic gonadotropin levels at 200,000 milliunits per milliliter. The sagittal and cross images from a grayscale ultrasound show an enlarged uterus with multiple anechoic spaces within it, and an echogenic intrauterine mass that correspond with an enlarged placenta with multiple cysts of varying shapes and sizes. There was no embryo or fetus within it. The evaluation with color Doppler showed no vascularity, and the ovaries were normal in size and shape, as we can see in this image that correspond with the right ovary and the left ovary. With these findings, we should think in the differential diagnosis of the abnormal gestational sac and contents, and as we routinely evaluate the whole placenta in orthogonal views, we must be able to identify the anatomic location of a mass. And if the mass is within the placenta parenchyma, we should think in the placenta lake and intervillus thrombus, chorangioma, and intraplacental abruption. The placenta lake and intervillus thrombus are often seen together. The lakes will have a swirl flow, and the thrombus will have no flow. We will see an hypoechoic round or oval mass surrounded by a normal placenta, as we can see in this image. And the chorangioma is a benign vascular placental tumor. The common location is on fetal side of the placenta near to the cord insertion site. And the ultrasound features will be a well-defined mass that is generally hypoechoic with variable amount of blood flow using the color Doppler to assess vascularity. In the placental abruption, it is important to identify the abruption location, which can be marginal, retroplacental, or preplacental, and the thick placenta may be the only finding that we can see. An acute hematome will be hypoechoic to the placenta, and as we know, the blood becomes hypoechoic with time. And as we see in this image, the hypoechoic hematome that is behind the placenta, so it corresponds with an old retroplacental abruption. And if the mass is replacing the placenta, we can think in a complete hydathiform mole or a placental mesenchymal dysplasia. The complete hydathiform mole will present with placental multiple cysts and an embryonic gestational sac, and it will be associated with transvaginal bleeding. And in the placental mesenchymal dysplasia, we can find a placentomegaly and abnormal chorionic bleeding. And these findings are, in this image, we can see an enlarged placenta with multiple cysts. And this pathology we have a secondary severe fetal growth restriction. So our ultrasonographic findings consist on a complete hydathiform mole, which is part of the gestational trophoblastic disease, which classify into hydathiform moles with partial and complete form, and in malignant gestational trophoblastic disease with the invasive mole and the choriocarcinoma. This occurs in about 1 pregnancy out of 1,000, and the risk increases at the extremes of the reproductive age and with previous abortion. In this scheme represents the spectrum of the gestational trophoblastic disease with the partial and complete form of the hydathiform mole. And if any of these presentations do not receive any treatment or have a persistent elevated beta human chronic gonadotropin levels, can develop the malignant gestational trophoblastic disease, which can be the invasive form mole with no metastatic disease, or the choriocarcinoma, which the mole invade the myometrium and had a metastatic disease. The complete Hayati-4 mole occurs when a single haploid sperm fertilizes an ovum lacking of maternal genes, followed by duplication. And the clinical presentation will be a vaginal bleeding, the abscess of fetal heart tones, an enlarged uterus, hyperemesis, and elevation of beta human chorionic gonadotropin levels. The ultrasonographic findings will be an enlarged placenta with multiple cysts of varying shapes and sizes, and the best imaging clue will be known as a snowstorm appearance or bunch of grapes. There will be no embryo or fetus, and it can present an ovarian tecalothene cyst that presents in 25 to 55%. As we can see in this image from a transvaginal ultrasound, shows an enlarged ovary with tecalothene cyst, and that cause a multiseptated appearance, and these are often bilateral and associated with high levels of beta human chorionic gonadotropin levels. And the partial Hayati-4 mole is the result from the fertilization of an haploid ovum and the duplication of the paternal haploid chromosomes. And fetal tissue is often present. The ultrasonographic findings will be a thick placenta with cystic changes and peripheral vascularity, and may be associated with fetal parts. In this image from a transvaginal scan, shows an aggravate uterus with a yolk sac and an alive 8 weeks embryo. And on the right image, we can see a color Doppler ultrasound with an enlarged placenta with multiple cystic spaces that consist with hydropic villi. The invasive mole is characterized by an enlarged heterogeneous cystic intrauterine mass with an increased vascularity that extends into the myometrium, and it is unusual to metastasize, and is the most common form of the malignant gestational trophoblastic disease. This is a sagittal sonogram that shows an enlarged uterus with a complex anterior myometrial mass, and in the right image, we can see a color Doppler ultrasound that shows a fluorid color mosaic pattern in anterior myometrial tumor. So we should consider repeating the imaging if the chorionic gonadotropin levels persist elevated after treatment, and we can perform an ultrasound to look for myometrial vascular cyst, or a CT and MRI to evaluate for extrauterine extension and metastatic disease. The treatment will be dilatation and curettage with serial human chorionic gonadotropin measurements for the complete Hayati-4 mole, and for the invasive disease will be necessary to use a single agent or a multi-agent chemotherapy, and the hysterectomy in non-responsive cases if fertility preservation is not desired. Thank you.
Okay, good morning. My name is Jorge Vélez, and we'll keep going with the session of interesting cases. The clinical issue of the patient was a middle-aged male that arrives at the ER with drug-resistant seizures. CT scan, a non-enhanced CT scan was ordered. In these two actual CT images, at the level of the pineal gland and the lateral ventricles, we see evident unilateral brain parenchymal volume loss. of the right hemisphere, which is characterized by prominent cerebral sulci and ventriculomegaly of. Okay, on the coronal reconstruction of the same CT scan, it's demonstrate that the right-sided generalized parenchymal loss, which was very evident, by the ventricular asymmetry, the prominence of the sulci, and the perisylvian and temporal regions. On this comparative sagittal reconstruction, we see that the right ventriculomegaly it's very evident compared to the contralateral ventricle, which was of smaller size. As well, we can see that the cerebellum is respected on the right side, and we can see that the cerebellum fissures at the left side are more prominent or more visible. Okay, this was Rasmussen encephalitis. The definitions of this disease is that it is a chronic, progressive, unilateral brain inflammation of uncertain etiology. It is characterized by hemispheric volume loss and difficulty controlling focal seizure activity. It is characterized as well by image as cortical inflammation. Okay, no, as in the pathology, as cortical inflammation, neuronal loss, and gliosis. On image and CT and MRI, we can see at first normal CT or MR, then a cortical swelling, and then atrophy. The location of this disease usually is one cerebral hemisphere. It is usually unilateral, predominantly frontal and insular and parietal lobes. As we can see on these images, this one is an axial T2 MRI that demonstrate the diffuse atrophy, which is predominantly on the insular cortex, which is typically involved in Rasmussen encephalitis, and the right front lobe. It is usually of the precentral and inferior frontal atrophy. Not usually, it is rare that the cerebellum is affected, but we can see contralateral cerebellar volume loss, as we were seeing in the case that I presented. Okay, in the other image, which is an axial T2 as well, we can see the parietal involvement of the atrophy. It is generalized to the right hemisphere, but we can see it's predominantly on the parietal lobe. The CT findings could be initially normal, and then it could course with atrophy. On the not enhanced CT. On the contrast enhanced, we can see usually no enhancement, and rarely we can see as well transient peel or cortical enhancement. On the MRI, on the T1, we can see the volume loss, and in early phases, we can see the sulcal effacement due to early swelling or the phase of inflammation. On this image, which is a coronal T1, we can see the parietal, cortical, and subcortical atrophy. The frontal and parietal lobes are commonly the first regions to be affected and to show changes on the MRI. On the lower image, we can see a T1, which was from a 4-year-old patient with chronic Rasmussen encephalitis. And this image demonstrates the marked atrophy of the frontal lobe. with the predominant insular involvement, as well as the frontal involvement with the ex vacuo dilation of the frontal horn of the lateral ventricle. On the T2, we can see the early focal swelling of the gyri. We can see as well the gray-white matter blurring and the T2 signal prolongation. It could affect basal ganglia and hippocampi. On the late stages, which are these images both, we can see atrophy of the whole hemisphere or a lobe. On these two T2, we can see the atrophy of the left hemisphere, predominantly on the parietal lobe, and that is affecting the basal ganglia as well. On the lower image, we can see T2 with an end-stage Rasmussen encephalitis with severe atrophy of the whole hemisphere and with high signal of the brain parenchyma, which is gliosis. On the flare, we can see the cortical and subcortical areas of hyperintensity that progressively increases over time, which is gliosis. And on the late stages, we can see the atrophy and the encephalomalacia and gliosis. On these two images of flare on axial, we can see the prominence of the left perisylvan fissure due to the volume loss, and there is associated cortical gliosis in the frontal operculum. On this axial flare shows the left hemisphere atrophy as well, gliosis, which is manifested as hyperintensity on flare. On the magnetic susceptibility imaging sequences, we will see them typically normal, which means that are non-hemorrhagic or without calcification, which is important to see with the differential diagnosis that we're going to see later. On the diffusion, it's non-specific. It could have restricted diffusion areas. On the contrast-enhanced T1, we usually don't see any enhancement, and occasionally we can see subtle pile or cortical enhancement. Okay, some of the differential diagnosis, it's the Sturge-Weber syndrome, which characterized clinically with port wine facial nevus and enhancement of pile angioma. It is progressive hemispheric atrophy as well, unilateral. But the main difference is that we are going to see the cortical calcifications. On this T1 enhanced coronal MRI, we can see the enhancement of the thickened pia, which is the pile angiomatosis, and an enlarged subarachnoid space, which is the atrophy all over the right hemisphere. And we can see the respect of the contralateral hemisphere. On this axial skull CT, we can see the calcifications in the precentral and the postcentral sulci. No, gyrus, which is characteristic of the Sturge-Weber syndrome. Another differential diagnosis is the Dyke-Davidoff-Mason, which is also unilateral brain atrophy. We can see, to differentiate this one from the Rasmussen encephalitis, the compensatory calvarial thickening that we can see on this T2 MRI. We can see also elevation of the petrous ridge and hyperaeration of the paranasal sinuses, which we can see in this one, the frontal left sinus, very enlarged. And this will be following an in uterus or perinatal infarct. This disease is also known as prenatal or neonatal hemispheric infarction. Okay. The other differential diagnosis is the hemimegalencephaly, which is an hamartomatous overgrowth of the hemisphere, and it is probably misnamed because usually it's not affected the whole hemisphere, but just some one lobe. We can see enlarged hemisphere with abnormal thick gyri, and the gray matter and white matter junction will be blurred. In this case, where the confusion lies, it's because, or the why this disease is a differential diagnosis is because of the we see an enlarged contralateral hemisphere. It could make the other hemisphere look with atrophy. On this T1 MRI, we can see myelin maturation, which is characterized by high signal. There's also the blurred gray-white junction, which is characteristic of the cortical dysplasia. As well, we can see shallow sulci and then a large subarachnoid space. On this T2, we can see the same features. Also, we can see some cortical dysplastic veins, which are characteristic of this disease, and that will be all. Thank you.
Okay, good morning. My name is Lorena Reyes Gaitan, and this is my radiologic and clinical case. Okay, so it's about a 25-year-old patient with medical history of HIV infection and cutaneous lesions in both hands, referred by the clinician as suggestive of Kaposi sarcoma. Okay, so this patient come to the ER presenting fever, cough, and dyspnea with subacute onset and progressive worsening. So, as part of the diagnostic approach of this patient, a chest CT scan was performed. In this actual view of a high-resolution CT scan, we can identify multiple lung cysts, which are located in both lungs, which vary in size and in wall thickness. So in this lower level image, we still can identify those cystic lesions, but we can also observe a small area of ground glass opacity on the left lung, on the right lung, sorry. Okay, in this other image, we can saw that the affection is like it's more diffuse, predominantly periheliar, and it tends to spare the periphery of the lung. Okay, in this image, we can see more diffuse ground glass opacity, also in both lungs. So, as a diagnostic exercise, it's important for us to remind, first of all, the definition of a cyst. So, according to the Fleshner Society glossary, a cyst appears as a round parenchymal lucency, or a low attenuation area. It has a well-defined interface with the normal lung, and the wall thickness is variable, usually thin-walled, of about 2 millimeters. Okay. Lung cysts usually contain air, but occasionally can contain fluid, or solid material. And this term is often used to describe enlarged wall air spaces. Okay, so I found this algorithm which was published on the Chest Journal on the year 2016. In this algorithm, the author proposed to us that whenever we face chest image with cystic air spaces, the first step we must take is to define if these lesions are true cysts. So, if they are not true cysts, we must exclude diseases like cavitary disease, cystic bronchiectasis, or centrilobular emphysema. But if they are true cysts, then we must differentiate them between intraparenchymal or subpleural. And among the subpleural cystic lesions, we must describe bullae, honeycombing pattern, or paraseptal emphysema. Then the next step when we talk about intraparenchymal cystic lesions is to define if they associate with another high-resolution CT findings. If they are not, they can be solitary or incidental, like in bronchogenic cysts, pneumatocyli, and incidental cysts. Or it can also be a multifocal disease, like we can identify on Berhot-Dubs syndrome, which is also known as a folliculin gene-associated syndrome, characterized by multiple lung cysts, and also bilateral renal tumors, mainly chromophobe renal cell cancer, and also other cutaneous manifestations. Another pathology to consider is tracheobronchial papillomatosis, lymphoid interstitial pneumonia, malignancy, infection, lymphangioliomyomatosis, or also the solitary incidental lesions, which include incidental, as I told you, include mainly incidental cysts. The next step is to identify if they are associated with nodules, like in lymphocytic interstitial pneumonia, in amyloid, or also in pulmonary Langerhans cell histiocytosis. And when they associate with ground glass opacity, like in our patient, the two main differential diagnoses are pneumocystis jirovecii pneumonia or desquamative interstitial pneumonia. Okay, so in this case, when we have ground glass opacity, there are some different characteristics among pneumocystis jirovecii and desquamative interstitial pneumonia. This interstitial pneumonia is usually presents with small cysts, which are usually few, universal ground glass opacity, centrilobular and ground glass nodules, which are usually scanty, and it's more common in older patients, mainly smokers, which associate with cardiovascular disease, use of sirolimus, or also toxic inhalation. And patients present with dyspnea and cough. While in the pneumocystis jirovecii pneumonia, the ground glass opacity is more diffuse. It can be associated with septal thickening and occasional cysts. The cystic form of this pathology is more common after a long-term disease. It's more common in younger patients, mainly on subacute clinical course, mostly in patients with AIDS, with a CD4 count less than 200, presents with fevers, dyspnea, mainly over weeks, also cough, constitutional syndromes, and with a low PaO2 level, also a high LDH level. So pneumocystis jirovecii, despite the use of effective antiretroviral therapy, it's still the most common opportunistic pulmonary infection in patients with HIV. As I told you, cystic lesions is usually in long-term infection, but they are not uncommon. Actually, it can occur in about 34% of the cases of CT scans. Okay, cysts usually are multiple. They tend to be at the upper lobe, and they can vary in size, shape, and wall thickness. They can also rupture and cause a pneumothorax, which is often difficult to treat. Okay, so other findings of pneumocystis jirovecii are diffuse, scattered, or extensive ground glass opacity, cysts in about, as I told you, 30% of the cases, and there also can be septal thickening characterizing crazy paving. Even when the chest X-ray is normal, it's important for us to take a high-resolution CT scan. Diagnostic of this pathology can be through sputum, bronchoalveolar lavage, monoclonal antibodies, or PCR, and the treatment is, as we know, trimethoprim sulfamethoxazole. Thanks.
Good morning. My name is Jaciel Maya Garcia. I'm resident of the second year of the in the radiology program of Centro Universitario de Imagen Diagnóstica, and today I'm going to talk about about this interesting case. The patient was 13 years old male. The date of admission was the November 19, 2017, and the main symptom was altered consciousness. About the patient's family history, the mother and the father was apparently healthy. Just the brother was diagnosed with absent seizures that was treated with valproic acid. On the patient medical history, the patient was previously a healthy kid. About the history of the illness, he began his illness on May. He began to present with headache, mostly on the left hemicranium. But the patient was asked took a CT scan of the head. They saw a hypoattenuating lesion on the brain parenchyma, and he was referred to the hospital, to General Hospital of Nuevo Laredo. But because of the economic reasons and because of the patient was asymptomatic, he didn't go to the hospital, and he came back on October because he had headache and almost dizziness, and then in November he got somnolence, irritability, visual hallucinations, and lower extremity hemiparesia, almost dysphagia. That's why he went to General Hospital, and they ordered a magnetic resonance of the brain. Because of the findings, they send us the patient to our service. On the physical examination, the patient has had cyalorrhea, uvula deviation, tongue deviation, and on the chest he showed a nevus on the anterior wall that was with irregular borders, not elevated, and the abdomen was normal, and the extremities was also normal. On the neurologic examination, the patient had somnolence tendency, stupor, time and space disoriented, and slow speech. he also got the right positional nystagmus, not predictable dyskinesia, left dysmetria, but he had no dysdiacokinesia. On the lower left extremity, he had paresis 4 of 5, diminished osteotendinous reflexes on both lower extremities. On the cranial nerves, he had bilateral paresia of oculomotor nerve, left paresis of the 6th cranial nerve, supranuclear paresis, left paresis of the 7th nuclear nerve, and he had absence of the gag reflex, and sternocleidomastoid and trapezius weakness. Well, this patient came to us and we ordered, well, this is the MR of the patient that had took on Nuevo Laredo. Here we could see a T1 enhanced, contrast enhanced image on the left, and you could see a lesion on the basal ganglia that was Riemann-Haynes heterogeneous, that show rim restriction on the diffusion weight image, and also a hemorrhage component on the magnesium paramagnesium sequence. On the right image, on the sagittal reconstruction of the T1 weighted image, you could see that these lesions are multiple. They are predominantly on the basal ganglia and subependymal location. This was the CT scan that was ordered here in our hospital. It was a non-contrast CT scan, and we saw this lesion on the basal ganglia and almost the other lesions. That was the patient still got deteriorate, and he was bring to the UC the department. This is the laboratories of the patient. I'm just gonna remark on the lumbar puncture that was clear. The cells was elevated with predominance of lymphocytes. The glucose was low compared with the capillary glucose, and the proteins was on 42.5 milligrams per deciliter. The QOH on the cerebrospinal fluid was negative. The culture was negative, and the Searle-Nielsen also was negative on the CSF. But the cytology show typical lymph cells that was compatible with lymphoma versus brain metastasis. The serology was almost completely negative to Toxoplasma. The HIV ELISA was negative, the cytomegalovirus and antigen of hepatitis B was also negative, and the hepatitis C virus was negative. The pediatrics asked to the dermatologist to perform a biopsy from the nebus of the anterior wall. That the result to be a compound melanocytic nebus, and also the galactomannan on the cerebrospinal fluid was negative. But because of the results of this laboratory and the image findings, we think we have many differential diagnoses, and but the patient was still getting worse. Um, this is the CT scan that follow the deterioration of the patients when you could see ventriculomegaly, and that was with subependymal extravasation of the cerebrospinal fluid. But the patient was asked to the neurosurgery department to perform a ventriculostomy. The neurosurgeon said it was got some examples from the fluid that he saw also was brain material liquefied. Well, for the revision of this subject, I just want to give you a mnemonic for the the multiple rim enhancing lesions. This is the mnemonic Dr. Magical, like us. The D is for demyelinating diseases like multiple sclerosis and acute disseminated encephalomyelitis. Well, the multiple sclerosis, you could see multiple lesions in some enhancing, some other not enhancing, but this is because of the multiple stage of the disease. And in the acute disseminating encephalomyelitis, there is important to be a history of previously vaccination or a viral infection. The R comes from radiation. You could see multiple lesions with rim enhanced. These lesions should the different diagnosis of these lesions is those are the metastasis or recidiva of the tumor, but in these lesions the MR spectrum and the MR perfusion is useful to differentiate, and the perfusion, well, the radiation lesions show us hypoperfusion, and the tumor lesions show hyperperfusion. And on the spectrum, the metastases show a peak of choline, the opposite of the radiation lesions. Well, metastases are one of the most important differential diagnoses. Most of the metastases have substantial vasogenic edema, regardless of the little lesions. The abscess, that's another important diagnosis, and these lesions you could see a tiny rim enhancement peripheral on the lesions. On the T2 weighted image, you could see the hyper intense lesions on the center that they also got restricted diffusion. Other lesions are glioblastoma, that is a lesion that generates from a glioma. These lesions often show central necrosis and multiple substantial vasogenic edema. Also on the spectrum, these lesions show a peak of choline, and perfusion. These lesions are hyperperfuse. The I comes for subaqueous infarct. The infarct only show enhancement the first 2 weeks before the infarct, and it tends to be a jury form. The enhancement follows the form of the jury. And the contusion, well, the history of trauma is also important. These lesions could enhance also in CT and MRI images. The A comes from AIDS. The most important lesions or more prevalent are the Toxoplasmosis Lesion, and the differential diagnosis, the most important differential diagnosis is lymphoma, but these lesions don't show a peak of choline on the spectrum, and it doesn't show restricted diffusion. The lymphoma, well, this was a important diagnosis, differential diagnosis in our patients because of the location of the lesions. The lymphoma tends to be on the subependymal location, and also periventricular. That's why this was an important diagnosis. Coming back to the patient, well, the patient unfortunately died, and he was requested autopsy of the patient that report brain abscess on the basal ganglia with microorganisms morphological compatible with amoebas. He also showed cerebellar necrosis, hypoxia, and neural edema. These are the images from the autobiopsy, and here you can see the microorganisms that compatible with amoebas. We think the most probably agent is Balamouthia mandrillaris. That's it. Thank you so much.